Pediatric pulmonologist at Seattle Children's. And this is just going to be a great session today. So we're so excited that you're here. Today we are going to be focusing as part of our cystic fibrosis newborn screening webinar series on educating pediatricians and primary care providers on cystic fibrosis newborn screen. And so we have three great speakers joining us today. So Beth Tarini, Michelle Gornick, and Susanna McColley. And they are going to be sharing their experiences, their knowledge, and their wisdom. So we are doing many webinar series. So we would love it if you join our other ones. Plus, if you missed our other ones, you can see all our past recordings on here. If you want to pull out your cell phones, here's a QR code, but also we will be sending you many emails as well. So don't you worry about that. But there's a bunch coming up that we're super excited about. All right. And these webinars are going to be focused on everything from the dry spot that's collected and sent from the public health department to the lab testing, IRT levels, the CFT variant panel, sequencing, and really about communication of the results to the primary care providers and then to the families as well. The full experience we're working on today and over the next few weeks. And if you haven't heard, we have a new guideline on cystic fibrosis newborn screening. The link is going to be in the chat if you haven't read it, and we really encourage you to read it. It's just full of lots of tips and all the research behind it. But this is really a nice summary of the different aspects of it. We have 7 different recommendations from up at the top about the IRT levels, to 3 different recommendations about the variant panels and how to perform them, a very high IRT level. And then really what we're going to be focused on today is down here at the bottom. And this is really about the communication of the newborn screening results to both the PCP and the CF specialist. And while that sounds very simple, we all know that this is a really complicated piece, and such a key component of newborn screening is making sure that everyone knows who needs to know and how the information is communicated, is done the least traumatic and in most informative way possible. So that's what we're going to be focused on today. And so these are some of our details and our recommendations. And so just to go quickly, so that notification of a positive newborn screen should involve the primary care provider, because often families have relationships and have increased trust. Notification of a positive newborn screen should also involve the CF specialist and help ensure that there's no barriers to the child coming in, and then also ensuring that the right information is communicated to the family. And then overall, that the medical community should really be educated that newborn screening is only a screening test. It's not a diagnostic test. And that the medical community really needs to understand that CF occurs in people of all races, ethnicities, and ancestries. So those are just a little brief overview, but please read more in the guideline. And then here's a little bit of evidence of the need that we really understand that there's a lot of work that we need to do about newborn screening. This link will also be in the chat.
Yeah, and this is based off of a study that Marcy and I did a few years ago. So we actually did some interviews with CF centers and newborn screening programs. And in there, one of the things that we found when we talked to them was some of these quotes that you see here, that sometimes the pediatricians tell the families not to come in for evaluation, and instead they'll just repeat the IRT. And so by time the CF center saw them, the families had had 3 IRT specimens repeated, but they hadn't actually gotten care, so they delayed the time that they got to care. Or what we heard over and over again was that pediatricians in some of the states believed that non-white families couldn't actually have CF. And so they didn't really refer the kids because there's this misperception. And so that's kind of what informed one of the reasons that we're having the conversation that we're having today, and some of the work that's being done. So that's kind of what's kicking this off. So with that, we're going to turn it over to our speakers. So we're going to start with Beth and Michelle.
Hi, thanks for having us here today. Just as a quick introduction, some of you may have been on a previous call that we presented some research on that we've been working on for a while, but I'm Michelle Gornick. I'm a geneticist by training and a statistician, and a lover of any sort of data and presenting data. And Dr. Tarini is a card-carrying pediatrician and has a lot of other degrees too, as you can see. I did notice when I was making this slide that we're missing a JD, so I feel like somebody needs to.
My husband says it's not possible.
Okay, but we're not totally covered yet, but someday. So, okay, so let's see. Okay, so I wanted to start today with talking about a recent report that was commissioned by the National Academy, done by the National, run by the National Academy of Sciences, Engineering, and Medicine. For those of you who might not be familiar, the National Academies is a private nonprofit institution that provides advice on challenges that are facing the nation, and with the hopes to inform policy and the public on advances in science and things that are relevant to science and medicine today. So specifically to newborn screening, there was a congressionally mandated consensus study, I think they called it, sponsored by Health and Human Services, that wanted to examine the newborn screening system in the United States, as well as some of the processes and research that is going on, in order to create a roadmap that would strengthen the program over the next 5 to 15 years, I think was the aim. So this report just came out in the beginning of May of this year. And I pointed out to Megan at the beginning that I noticed that her background said May is Cystic Fibrosis Awareness Month. So I thought that was maybe some kind of happy coincidence or something. But anyway, okay, so relevant to what we're talking about today, the report, and I'm just going to read this to you, but I thought this was an important sort of segment from the report that said that providers can feel ill-equipped or unable to engage with families about newborn screening due to part to insufficient knowledge. Education on the mission and practices of newborn screening, how to routinely integrate and disseminate resources on newborn screening into care, and the fundamentals of genetics would prepare providers to responsibly communicate with their patients about newborn screening through the prenatal and postnatal period. So before we sort of get into what is going on, what we know about best practices in communication and educating providers, I wanted to kind of start with some maybe current miscommunications or misunderstandings, and then talk about a little bit about what we know works. And then Dr. Tarini is going to take it over and talk about some specific research and data that we know about maybe what we could better improve. And then I'm going to bring it back to like what the National Academy's report is suggesting we do with that. So, okay. So to start off, some myths about primary care physician communication. And I would say this applies broadly to newborn screening, but I think specifically, I'm going to give some examples to cystic fibrosis. So many of the challenges that we see in cystic fibrosis screening, we also see in newborn screening in general. So, okay. So one of the first ones we thought that was important to point out is that one of the myths about pediatrician communication is that it's or primary care communication is that it's a pediatrician who's going to be disclosing the screening results to you. And often it is a nurse practitioner or possibly somebody from the state or a genetic counselor. So it's not always the pediatrician per se that will be disclosing the screening results. Another important myth about communication is that it's a provider who knows the family. So it's not always the case that it is somebody who is familiar with the family and what maybe the specific needs of the family are. The third myth is that it's a provider from the child's practice. So it is not always somebody from the practice. It could be somebody from the hospital, it could be somebody from the state or a different center. But that is often surprising to families. the fourth myth is that it is a provider who's familiar with cystic fibrosis. So, you know, pediatricians and primary care providers, their role is to provide care across the spectrum of health, and it is not often the case that they see a newborn screening result. So they may or may not be familiar with the newborn screening process, but also specifically to having a patient or a family that has been impacted by cystic fibrosis screening specifically. The fifth sort of myth about communication is that the child had prenatal testing that was negative for CF, and so they can't have CF. And that is something that is impacts the pediatrician or the primary care physician or whoever is communicating results, but also the families who are receiving information about a newborn screening. So, you know, I wanted to put this up as just kind of a overview of the newborn screening communication pipeline and give you some examples of like where the breakdown in screening specifically for cystic fibrosis happens. But again, I think this is something that happens for all newborn screening conditions, not just cystic fibrosis, but we're going to just sort of highlight things that are relevant to cystic fibrosis. So today we're really focusing on the reporting and the interpretation of the results part of the pipeline, but there is definitely work that needs to be done, and the National Academies report really addresses this entire sort of communication pipeline, not just what we're going to be focused on today. But specific to the reporting and interpreting results, the Cystic Fibrosis Foundation in 2025 released updated guidelines, as I'm sure most of you are familiar. And one of the things they emphasized is that about 30% of primary care providers misinterpret the presumptive positive newborn screening result as something that's not urgent. And I think that's one thing that we need to keep in mind, and something we'll talk about a little bit in the next few slides. Another thing that came out with these guidelines, and I think that is also important to keep in mind, is in the reporting and interpretation of the results phase, is that often diagnoses are missed in Black and Hispanic infants. And this is somewhat exacerbated by the interdisciplinary communication about variant significance and types of variants that might be presented as part of this process of screening. So that's somewhat of what we're going to talk about today. So next, I wanted to just kind of, before we get into sort of what's not working or what we could improve maybe, highlight some of the things that we know do work. So there has been a lot of research. There is a lot of data that shows that there is, we can make evidence-based recommendations on what is working. And I think that's what the guidelines recently the updated guidelines really show. But I think I just kind of wanted to review. There are things we know that work. I think, the first is sort of this around this timeliness metric. So there's something that we refer to as the 5-day rule, which is like communicating presumptive positives for cystic fibrosis within 5 days of birth. And that's per the APHL guidelines. We also talk about this like closed loop verification. And this is where there's sort of a mandate or the electronic health record alert to for unreported results to automate referrals to cystic fibrosis centers when there is a positive newborn screening result. Some of the, around the optimizing confirmatory testing, things we know that work for primary care physicians specifically is that the communicating to primary care physicians that they should refer families to a regionalized testing center where they would then have a sweat test performed within the recommended guidelines, and hopefully the addition of CFTR sequencing within to resolve any discrepancies and screen positives or inconclusive diagnoses. And I think the third thing that we know that works well for primary care physicians and for families is family-centered communication. So here I'm talking about some recent studies that found that when primary care physicians calls are paired with same-day genetic counselors or a nurse practitioner, to communicate information with families, there was a reduction in anxiety scores in parents from about a 8 to a 3 on a 0 to 10 scale. So this really shows that this dual notification of the provider calling and having a genetic counselor or somebody who maybe would be able to talk with the family really reduces anxiety. And I think the other part here with family-centered communication is that what we previously noted is that cystic fibrosis does not just impact white families, it impacts families of all ethnicities, and culturally adaptive material should be adapted accordingly so that it's not just centered around families that are white ethnicities. So, okay, I think this is where I'm going to hand it over to Dr. Tarini to talk
Yeah.
about some of the research.
Yes, and so thank you, Dr. Gornick. So there's not been a lot of research in this area. A lot of the data we have is anecdotal about how primary care providers communicate out of range results with patients for newborn screening. I was part of a project we led when I was at Michigan that we interviewed providers about cystic fibrosis. And specifically, it was funded by the CF Foundation, actually. And we noted that there was a variability in notification methods used. As was noted, it's not necessarily clear that it happens by phone or in person, and it can be delegated to the staff as well. And so you're not necessarily sure it's the PCP that's actually giving the information. And there are gaps in the provider preferences. And in addition to what they're saying, to that other point about their decision tree and their communication about, do you do a repeat IRT? Do you refer? Do you do X, Y, or Z? There's also the idea of balancing factual information communication with emotional support communication, because in essence, this is can be considered breaking bad news. This is unexpected news to the family. So in some ways, from a communication standpoint, it should be viewed as such in the delivery. Next slide. And so some effective communication tools that can be used, standardized training, although the challenge with standardized training is to train people for something that happens rarely or intermittently, and so you don't really get the practice. So we train PCPs and then nothing happens for a year, and then it happens and then they haven't really been practicing. So that's a bit of a challenge. So probably having much more point of care support that are involve checklists and specific guidance on what to say and what the content is and how to say it is probably going to be the more effective and cost-effective means of going forward. Next slide. And so you'll see here, I worked with the newborn screening program at Michigan. They had the same problem that was raised before, that the CF program came to them and said, well, we're getting parents coming in with 2 mutations and being shocked that we're telling them their child has CF, and then we're having people come in with a child with 1 mutation, being convinced the child has CF, and they're saying it's that what the PCP told them. So we went back and talked to the PCPs and looked at the documents. And it turned out at the time, I don't have any of those right now, but there was no mention of the mutations in the paperwork that was going to the PCPs. So they really weren't discussing the results. And there were a number of reasons for that. That was intentional at the time, that it was felt that placing the discussion of mutations in the hands of PCPs was putting them in a zone where they may not have the expertise. The problem was, in doing so, it restricted their ability to have a functional and probably an accurate conversation about the child's risk. And so after much deliberation, we all agreed we'd go forward and include the mutation results on the forms that went out to the PCPs, and then design them in a way that's results forward. And so you can see here, I'm not as what's the word? I'm not as creatively design inclined as Dr. Gornick, who's made these slides. So you see shades of gray here, but the ideas here are that you lead with what's the main point. that there's a what does it mean? There's mutations, and from those mutations, what's your risk? What do you do now that you know that risk? How do you discuss this with the family, and who do you contact for more information? So that right in up front, you would have these things in your face. You wouldn't have to search for them. Next slide. And so near-term actions you can take that the NASEM committee that I was a part of understood that this is a complex topic, involves many moving parts, very dynamic, and very sporadic. When this happens, it happens, and it's a high intensity, high stress environment. So there are a list of provided suggestions for how to go about sort of addressing the challenges here. And then next slide, 2 that sort of come out that might be achievable, which were suggested, were electronic messaging for newborn screening communication, back and forth with the programs and the healthcare providers, which may support more timely connection to clinical care. We all know that these are facts. And there is HL7 reports that do sometimes come in the portal. The problem is they come in the portal and the patients may see them first. So you have a separate issue there. So I do think looking at our entire communication process around newborn screening, both the results as well as the support and communication back and forth between the provider, the state, and the specialist is something to look at. And there are ways we can improve. Next slide. And also comprehensive follow-up status KPIs. So basically, really looking at, are we doing what we think we're doing? Are all babies receiving follow-up? Is there appropriateness of follow-up? Is there time to follow up? You know, when I was hearing the story about the 3 IRTs, it occurred to me, as the IRTs were coming in, did the state follow-up program say, why are we on the 3rd IRT? The child should already have been referred again. You know, that there was a lens into potential. Now, it also could have been they didn't know the IRTs were happening, but if this was taking weeks at a time, what was the, you know, what could the program have said? You know, it's been 3 weeks, we haven't heard from you. Oh, you've been doing 3 IRTs. Oh, sorry, that child should actually have been referred. So is there an opportunity there? Now I want to pause to say, and I said this before, you know, newborn screening is a program that was born. This is my sort of lens, talking with also others in the field, that it really was a case finding endeavor. It was not born of a screening mentality. Screening was a means to an end, of course, but in that way, this idea of having exhaustive data infrastructure and follow-up is really not been the history of the program, because when it started, there was really 1 to 5 disorders. You know, in the last 2 decades, we've added like 50 plus. And so we've really moved the program without the data infrastructure that the program had to accomplish its goals fine before. I'm sure there were problems, but now we're seeing the strain, because these programs were based on getting the children in, not also sort of having intense surveillance of every disorder and every timeliness episode. So I do want to give them a bit of sympathy, quote unquote, in that regard. Next slide. Oh, and that's it. I think the takeaway, the one thing I'll end with is, education is great, but education has to turn into action, and education does not have a one-to-one with action. Education can help direct the action. And I really push for the programs, and we've said this too, to sort of consider being very explicit and very explicit with those forms and what you want the PCP to do. Not leave room for error or guessing. You can educate them after you've guided them or alongside guiding them, but guiding them and directing them is probably should be primary.
Thank you. And I put this in the chat. We're going to save the questions kind of to the end. But if people have questions now, which is what I would do, I write them in so that we have them, you guys can see them and start thinking about them, and then we'll make sure that we have time for them, and that will help us too. So I want to make sure that we give Dr. McColley enough time to talk. But I just want to put out there that we would love to have questions and discussion. I think you guys have brought up a lot of great things and a lot of great suggestions and things to think about. So, Dr. McColley.
Thank you. And now I'm going to follow up with sharing some work that we've done for education and awareness for equitable and timely cystic fibrosis diagnosis. Next slide, please. So you all know that newborn screening for cystic fibrosis became officially recommended in 2004 at the time of this report. If you can toggle for me, Yvonne. And this is a slide. This is a figure that Phil Farrell, who did the randomized controlled trial of cystic fibrosis newborn screening and has led U.S. efforts for the Cystic Fibrosis Foundation and also some international efforts, created just to remind us all of the links of the chain that come between that dried blood spot and care initiation when a diagnosis is made. And so one of the things that we all know is that timely evaluation and treatment improves health outcomes. This obviously is the basis of newborn screening. We're focusing today on the primary care physician or proxy, I would say, to follow up on what Beth was just saying, and patient-parent communications. And so really, whoever contacts the family, that needs to be quick. And then ideally what happens is that there is some conversation that loops back to diagnostic testing. And my dream is that when these discussions take place, the primary care doctor or proxy says something like, her newborn screening shows she's at risk for cystic fibrosis. It's important to get her tested quickly. She may not have CF, but if she does, starting treatment can keep her healthy. And the parent will respond, I understand. I learned about newborn screening when I was pregnant and learned a little bit about cystic fibrosis. What test is needed and how do I schedule it? Now, obviously, this omits the important issue of emotion and grief and the perinatal period, which all of the parents in the room have been through. But that's sort of the concept that we are trying to we're trying to create tools and knowledge that can lead to this rapid turnaround from a positive test to diagnostic testing and, when needed, care initiation. Next slide, please. So one of the things that we did a few years ago is that we took a body of research that we had conducted under a Cystic Fibrosis Foundation grant and created a simple infographic that is for healthcare providers. And these are the key points. Again, giving people all of the details is not always what they can use in clinical practice. So the first thing is that we have shown that earlier evaluation is associated with better early life nutrition. And if you know about cystic fibrosis, you know that that early life nutrition is a health trajectory. For example, preschoolers who are heavier and taller have not only a better lung function when they get older, but they have a lower chance of mortality before adult years. We put a lot of information out. This is only some of it about the fact that delayed diagnosis and false negative tests are more likely to affect kids from racial and ethnic minority groups. And we can go back to the slide now. That link is for anybody who wants to do, and I think it's in the chat box or coming soon. Yeah, there it is. So we also wanted people to understand the importance of not delaying referral. So we found that not only kids from racial and ethnic minority groups had delayed referral, but that overall many kids with CF were seen outside of their first visit as a cystic fibrosis center was outside of the recommended range. But more importantly, for this overall cohort of babies with cystic fibrosis born between 2010 and 2018, 40% had weight for age percentiles below the 10th percentile at their first CF center visit. And while we had incomplete birth weight evidence, there is a lot of evidence that kids with CF have generally normal birth weight when you look at those percentiles. And then this was already shared earlier by Yvonne. There are lots of barriers, including socioeconomic status, geographic location of testing sites, time and transportation, but also bias against the diagnosis of CF in people from racial and ethnic minority groups. Next slide, please. So we came up with these key messages for primary care providers. One is that false negative tests can happen, and that comes from a variety of reasons, but we want to make sure that kids who have signs and symptoms of CF who have a negative newborn screening test still get referred. And this includes kids who have a full sibling with cystic fibrosis, because we've actually seen kids with a negative newborn screen who weren't referred in spite of that 1 in 4 chance of having the disease. Again, timely evaluation and treatment improves outcomes. And then really discussions about how clear communication can reduce misconceptions and improve the understanding of risks and outcomes. So we can go to the next slide now. So one of the things that we did is we took this body of research and we turned it into continuing medical education courses for primary care doctors. And this was sponsored by the Illinois chapter of the American Academy of Pediatrics. We wanted a timely solution. And so this was our best way to do this. And we have 2 different lectures that go into a maintenance of certification activity. And for those of you who know about board certification for pediatrics, this is necessary for everyone to maintain that. And this is a web-based, and it's focused on the office screening practice for managing newborn screening tests in general, with a little bit of content on CF, because we know that you should not have a different office practice for different newborn screening disorders. You should have a systematic way of managing those and notifying families, parents and caregivers about that. And so this has been offered through the Illinois chapter of the AAP, but it is available at no charge for everyone certified by the American Board of Pediatrics who's seeking MOC credit. So I've got a couple of screenshots on this. We have, I can't really give you a link for this because an individual has to sign into their own portfolio, but they can select a healthcare improvement or part for search in an online QI module. And then that takes them to this, and this is the tricky part, to choose the Illinois chapter. And then finally, they get this introduction, and I will note they're updating this to expire in September of 2026. So this is still active and available, and it can be done by every pediatrician in the practice, so they can do it together and really look at their systems. Next slide. Another thing that we did is that with help from the Cystic Fibrosis Foundation registry team, we put together a national indicator report. And this was, I should have mentioned earlier, this work was all done through a Centers for Disease Control and Prevention Chronic Disease Education and Awareness program. So this is one of their requirements, actually. And this is written in lay language, and it goes through, for example, an overview of cystic fibrosis. If you can click we have also really emphasized newborn screening and the importance of a newborn screening diagnosis here, and shared some data. So I showed you about delays earlier. We are getting better with CF newborn screening in terms of babies getting into CF centers faster. So the first time they're seen, but we also go through signs and symptoms of cystic fibrosis for people who are not aware of that. And we talk about diversity in the cystic fibrosis population, looking at reported race and ethnicity. And then again, that's okay, you can go ahead, really emphasizing these 3 key messages from that infographic that we created for primary care physicians. Next slide. Another thing that we have wanted to explore is how parents are experiencing notification and getting to care when they have a positive newborn screening test. And so this was a funded partly under that CDC grant and also by the Rosenau Family Research Foundation. And this was a cross-sectional study, and we collaborated with our health services research core. You can see also Megan McGarry's name on here, and Lainey Ross, who's a pediatrician and biomedical ethicist who has done a lot of work in newborn screening. But the person whose name you may not recognize is Michelle Wright, who co-founded the National Organization for African Americans with Cystic Fibrosis, because we know that in the US, there's lack of representation in community engagement and research in people who are Black or African American. And Michelle is also connected with other groups who focus efforts on people from minoritized populations. And this allowed us to get a very representative sample with overrepresentation of Black parents of children with cystic fibrosis. Next slide. So what we found in this recently published paper is that when people were, as has been noted before, only about 43% were notified by the primary care physician or a member of their office staff, about 25% from the birth hospital, and then about 31% from CF center or CF follow-up program. So this varies a lot by state. Many people were actually notified in person, and we didn't do a lot of complex analyses, but I assume that this is probably those who were notified by the primary care doctor or the hospital. Almost half by phone, though. And then most said that the person who notified you of a positive newborn screening test did give them information of how likely it was that your child had CF. And this is somewhat concerning just because it can lead to delays, particularly in kids who have no CFTR variants recognized by some indication that they might be low risk and maybe it's not a hurry to get in. So that's the other thing that we saw was that there were people using race, ethnicity, and family background to state how likely or unlikely it was to have CF. It was overall 43%, but that's still a lot of people who may be getting information that could sway their urgency to getting testing done. And then finally, most people also got information about the genetics. And you see these different numbers here because we did analyze incomplete surveys. We thought that was important. Next slide. I think there's actually a animation here. So another major issue of concern for us was how long it took. So the CF Foundation guidelines recommend that babies be seen within 1 to 3 working days of the family being notified of a positive newborn screening test. We used 1 to 3 days because we weren't expecting parents to remember whether they got a call on a Friday or a Monday. But we found only 21% had very early evaluation at a CF center. And then a fair number of kids, 34%, so now up to more than half. And I realize this 5-day rule is a little bit different, but if you're looking at within 5 days being reasonable, that was a little over a third. So we've got 56% now who are seen within 7 days. And then there were 38% of kids who were seen 8 to 14 days after the family received a call. And this is getting into a likelihood of treatment delay beyond the optimal time of probably 2 to 3 weeks, but certainly within a month, just because of the time it takes to process a newborn screening test. And then finally, there were 5% of kids who did not get in until they were 15 to more than 28 days old. So this is a small percentage, which is reassuring, but these kids had to have had treatment delay, starting those life-saving enzymes and supplemental salt. It's really important to avoid early complications of cystic fibrosis. We have a paper that is currently being written, but it was presented at the Pediatric Academic Society's meeting last year in 2024. And this was a general population sample using a Qualtrics panel that's maintained by our Health Services Research Group. And it was a total of 1,700 patients, again, representative of the race and ethnic background within the United States, and broad parent education levels. And so what we found here, first of all, was somewhat interesting. If you can click, Yvonne, we had different knowledge base of cystic fibrosis before people participated in the survey. We told them about CF as the reason we were asking these questions about newborn screening. But it was 87% of parents who identified themselves as white, and 63, 68, 66% of Asian, Black, and Hispanic patients. So different knowledge, baseline knowledge of cystic fibrosis. Now, 447 parents did have a child who had an abnormal newborn screening test. You can go to that. This is the money slide anyway. And so some of the things that they reported were, concerning. So feeling supported by family or friends was 45% strongly agreed, but a significant proportion either only somewhat or strongly disagreed. Feeling supported by the healthcare team, almost half reported that, only 24% strongly supported. Having difficulty understanding where to go for additional testing in healthcare was pretty common. Difficulty understanding the test results, strongly agreed 56%. Didn't know who to talk to, strongly or somewhat agree, was 47%. Feeling hopeful, 50% strongly agreed, that's positive, but people felt lonely, isolated, sad, depressed, and worried. And there are other studies on newborn screening that have shown similar results, but they have been smaller studies with qualitative interviews, most of which have had primarily white and college-educated parents participating. So this shows us some needs for improvement. Next slide. Based on this, we developed, and this was part of our CDC grant, we developed a public awareness campaign. And we developed, based on those results from both the parents with CF, but also the general population parents, some handouts, signage, and social media in both English and Spanish, and they included both general newborn screening messages and some specific to cystic fibrosis. And then we recruited a group of demographically diverse Chicago parents to give feedback on these handouts and signs and social media images before we deployed them. Next slide. And in general, the parents liked them. They thought they were visually appealing and that they were, you know, if you look at the second quote, I'm just thinking about my recent, childbirth experiences when you're giving information, no visual, no colors, love the way it looks. So that helped us feel like, people may look at this and pay attention to it. They also liked that it stressed the urgency of getting your baby evaluated if they had a positive newborn screening test. And then they were also very helpful in helping us design the final campaign. So they wanted more detailed information, which kind of surprised us. And we ended up on those QR codes that you probably noticed in the last slide. But they wanted to have more knowledge about what to expect from tests that could alleviate uncertainties. And then another thing that really struck us but didn't surprise us, click through to the next, is that parents, they felt that they were represented. So we had lots of different signs with lots of different babies from different backgrounds. They did feel like the place they wanted to get this kind of information was during prenatal office visits. And I don't know how many parents are in the room. I remember getting information on newborn screening when I was pregnant with my kids, and it was a pamphlet that was handed towards me. And both my kids were born after I was already a board certified pediatric pulmonologist. So I didn't need, I had heard of all this stuff, I guess I would say. So I liked this quote, and I think, anyone who's given birth to a child, if I think back to giving birth, I was so exhausted that I did not review any of the provided materials. Had I received this information in my 36-week appointment, I would have been more receptive and better prepared. So I thought that was an important message to get back. So what we did next is that we took it to the streets. And next slide, we have signs up on public transportation in Chicago now in both English and Spanish. So these are from the CTA. It's probably the red line. I ride this a lot. It's got a stop near my home. And next slide, we also have them on buses and then on billboards in different Chicago neighborhoods. So we have taken this out and also done a lot with social media. We have lots and lots of materials. And you saw the Lurie Children's logo on all of the signs in Chicago. And in fact, this was all done by our media experts at Lurie Children's Hospital. But these are available for anyone, and they can be branded with any hospital practice information or just used as they are. And these have been distributed to Yvonne and Marcy Sontag to disseminate to various attendees from these meetings, and they can get them to you. But we also have my research project manager also has these, and her email address is here. We would like people to use them. They could be edited if you wanted to, but we have, as I said, they're based on evidence, and then were tested with people in Chicago. And we also had a very wonderful bilingual pediatrician I worked with named Mariana Glusman, who looked at all of the Spanish language translations and actually changed them based on her own clinical practice and experience as a pediatrician. So I think they're pretty good. So a couple of more examples. Don't delay following up on abnormal newborn screening tests. You can go ahead. We've got everything in Spanish with appropriate translations. So the next thing that we are going to do is we are going to evaluate resident education and training about newborn screening using the last of our Rosenau Family Research Foundation grant. And shout out to Megan McGarry, who is co-PI for this. We are working with residency program leaders here at Northwestern University in OBGYN, family medicine, and pediatrics. We've already learned a lot from them about how people are and aren't trained, but we are going to be sending surveys to residency program leaders, sending mostly to directors, but inviting them to send them to people who are responsible for various curricular elements if those are the better people to do it. And so we really want to know what they're learning, both didactically and also experientially in continuity clinics or, at the hospital, and how this is being managed. Because we do think that how people are trained makes a difference in how they practice, and getting early awareness by resident physicians may be helpful in the long run. So, thank you all for your attention. I have many collaborators, more than I could note specifically, but I did finish up almost on time so that we can take questions. So thank you very much.
I didn't, Megan and Claire, are there questions in the chat? Does anyone have any questions for our speakers? You can come off mute.
While people are thinking, I guess for each of the speakers, it seems very overwhelming when trying to think about reaching all the PCPs and like changing things. Can you share some like very easy, not easy, but small or feasible things that programs or states could consider doing? That there could be something that they could, make a small change in their practice.
Megan, to reach them or?
To reach them or educate them, any aspect of it. Because I mean, it just seems like, I know that when we've been talking about it here in Washington, it seems very overwhelming. There's so many PCPs, so many different things. What are like some easy ways that people can start thinking about it for their state?
Yeah, I would say the first easy thing that's in their control is what they send out to the docs. Because that's what everyone's looking at. Let me be clear. We don't know that they're looking at it. That's what we think and hope they're looking at. So if that's what we're using as what we think and hope they're looking at, that's, I think, where we should start. And look at it to say, is this telling them what we want them to do? And I'll tell you, it's like in when I was in medical school, and I first went on the wards, they put like an x-ray up and everyone looked at it and they took it and they flipped it upside down, and all of a sudden things looked different because if you weren't looking at it the same way. So the programs need to not just look at it, but also invite other people to look at it and take the feedback, because you'll be like, it looks fine to me. But that's not the audience. The audience is the person picking it off the fax machine, and we could say it should look like X, Y, and Z. Some people, when we've done our work with Virginia, the feedback we've gotten from non-PCPs is, well, that really shouldn't go there because it's not important, but that's what we wanted the PCPs to do, so shouldn't it go first? That looks like it's a kindergarten thing. It should look more formal and have less white space. And we're like, actually, more white space is better in user-centered design. So I encourage them not only to look at their documents, but get eyes of the user on those documents. And it doesn't have to be a lot, and you can walk through it. They can call Dr. Gornick. She's an expert at doing it with us. So So it, and we're gonna have a plug if Jalili, if we get chosen at the APHL symposium to actually go through the basic tenets of sort of what you can look at. Like, here's the 5 things that are easy to look at and say, am I doing this on are we doing this on our reports? And so, and I'll end, but to say to Adrian's point, we have also have wanted to sort of see all the reports. It's not easy. I don't know that they're in one place. Not all the states share them, but I think that is an excellent starting point.
Thanks, Beth.
I mean, I'll just comment, I love that, report from the simplified report from Michigan that you showed, Beth. And I think people need, like, what does this test show? What should you do now? Talking points for families. And then, my hope would also be a negative screening test does not rule out.
Yes. That's an excellent point. That was not on there. That was in small, yeah.
Or growth, foul, fatty smelling stools,
Yep.
abdominal pain, rectal prolapse. I mean, we all know what they are. But I think that if you could have that 4-page report, and then if people feel there is a, we've all seen this, whether we're in public health or medical practice or just adjacent to it, there's this, they have to give you all the information.
Yeah, I was gonna say
X-ray. There were freckles in the right lower lobe. That's really all I hear about. But I got to get the bony thorax.
Yes.
Wow, like okay.
Yes.
So
I was gonna say, it's like, if anyone's been a patient, they don't even have to be a provider. You've seen lab reports, and what's happened is some combination of people are using frank lab reports or a hybrid of a lab report with an information pamphlet, to your point, Susanna. And if all you have to do is go to your own portal and be like, I don't understand, what's the result show? Is there an H, an L, or an N? And I got to hunt for it as the patient. So you live it every day, to your point.
Yeah, and I think so. So you give them simple. And then if you're lab people, like, they got to get the whole report, the whole thing.
Exactly.
So put it, that's page 2 through whatever.
Right.
So
Right. They can have all of it. It's not an either or.
You want to work on it. To Marissa's point in the chat, right? You could do this as part of a SIP application. Like, that's something that you could work on, that communication fits with improving the process. So and we only have 3 minutes. So Marcy would be very sad if she found out that I didn't do this. So really quickly, let me just say that one of the things that we do have as part of our funding is we have genetic resource centers. If your program is interested in getting improving your variant screening, there are 2 labs that you can contract out with, and they can kind of increase the number of variants that you screen for. That's one of the things that you can just think of. We are going to have another webinar, and it's going to be the families are going to talk this time. If you want to hear families talk, so you can go, and we'll send this out, but you can go and sign up for that. It's going to be fascinating to hear that panel. So just want to make sure that you know about those things. And so I'm happy to stay on. I don't know if our speakers can, if people have another couple minutes, but I just wanted to make sure we got that in. But I also want to give a big thank you to our speakers. There's a lot of work going on. I think sometimes we get stuck and we can't kind of think through, but I think we've gotten some really great examples, right, of what people have done to unstick us. And there are tools that are out there. I mean, I think, Dr. McColley and I were talking before, right? There's this great infographic that's out there. It's been sent out to everyone, and we forget that we have it, and you can take it out, or you can take pieces of it and use it, right? There are these materials that are out there that you could take and brand and use. Dr. Tarini shared what they did in Michigan. You can take that. Dr. Gornick shared last time what they were doing in Virginia that you can take and you can edit. Like, steal shamelessly from each other. That's what this is about, is sharing ideas so that we can improve the system for everyone. So we have another minute if people want to ask more questions, if people can stay on if they want. If not, Thank you.
I'll just say the family and parent one is going to be featuring the 3 moms who were on our newborn screening guideline committee. So they were full participants from beginning to end. And each of their stories are amazing. And they will also be talking about some of this communication piece as well. So it is very much going to be our most special of all of our webinars. So please join and then spread the word too. So.
Thank you everyone for attending. So it feels like we have a lot of questions. Thank you for attending. Thank you to our presenters for taking the time to share your stuff. We really, really, really appreciate it. So
Thank you. And everybody take my stuff. Your tax money paid for a lot of it.
Great conversation.
thank you.